Welcome everyone. If you don't mind, we are going to open the session. I would like to thank you warmly, István, for the very kind invitation to the European Parliament in Brussels. So welcome to this MEP Lung Health Group event on a stronger European response to rare diseases, the case of pulmonary hypertension. My name is Marc Quimbert. I'm the President of the European Respiratory Society and Vice Coordinator of the European Reference Network on Rare Respiratory Diseases. A warm thank you to the MEPs who have kindly agreed to host us at the European Parliament, and especially MEP Wu Hei, who is next to me, and MEP Soko, who will close the session. I would like also to warmly congratulate and thank Pha Europe, with Gergely Messeros standing by me, the European Lung Foundation, the European Respiratory Society, and Eurodis, who have organized and supported this event, which is very important because it marks the World Pulmonary Hypertension Day, which will take place on the 5th of May. So without further introduction, I would like to hand over to MEP István Wu from Hungary, but from the European Parliament. Thank you very much.
Thank you so much, Mr. President Humbert. Thank you, Mark. Yeah. Thank you so much. Good morning, ladies and gentlemen. I'm Mr. Wu Hei. You have to know that I'm a member of the NV committee, and I'm one of those who started to push the European institutions to establish this new program, the European Health Union program, and I can tell you, for me, it will be very strange, 2 or 3 hours. I don't know how long it will be because I'm not a doctor. I'm a lawyer, doctor, but I learned as a politician what I can do for the health structures. My parents, my mother and father, are doctors, so it's like in my family at home when 10, 15 doctors enjoyed each other, and I couldn't understand anything when they talked to each other. So this is the same moment, and I can tell you it's something which is very, very personal. It's a bit emotional moment for me because my last in-person meeting in the Parliament, where I was the host, happened more than 2 years ago. Which is, it was 800 days. Zoltán, who is my excellent advisor and colleague, who is responsible for the European Health Union project, he organized it. So I think we can tell Zoltán, thank you so much, because he did everything. I'm here to open it, and I will have a closing remarks, of course, and I try to understand what you are talking to me. So please, after these 2 or 3 hours, please give me some jobs, what I have to do here. How can I push all those opinions, what you would like to. Of course, this house, the European Parliament, isn't full with the professionals. You are the professionals. But when we are talking about the European Health Union project, then we have to realize that without the professionals, it's impossible to make good projects, political actions. I'm here to make a noise, to push the European Health Union project, and I have a big ambition to organize one strong lobby roundtable together with you, with the organizations, to have a common voice, to speak to the European Parliament, to push the European Commission, and to ask the Council, the Prime Ministers, for example, to give better position for the European Health Union and for the European Health Associations. So this is my job. That's why I will stop here, Zoltan wrote me lots of things, but most of these sentences about your profession. So I think I don't have to tell you what is the topic today. But I'm here from the beginning till the end. It's not typical in my life. My colleagues know very well. I like to open something and leave. I'm a politician, but I promised Zoltan I will be here and try to understand and learn. So thank you so much, Mr. President, and please do it, and I will wear the mask.
Thank you very much, Mr. MEP Istvan Ruhey. I try to pronounce your name as well as I can.
We have some Hungarian colleagues here.
And it's great to feel your energy and your support. I must say, as ERS President, that I greatly appreciate your willingness to support us. And we had meetings, virtual meetings in the past, but today is a face-to-face meeting, and it's a great opportunity to thank you in person. So thank you again. So we are going to have, we are going now to have a very lively series of presentations, followed by a panel discussion, and we will let you know how you can help us as patients, as doctors, and as a community. So the first speaker is Professor Marion Delcroix. She is the director of the Center of Pulmonary Vascular Disease at the University Hospitals of Leuven in Belgium. And she's going to give a talk on pulmonary hypertension, rare diseases, and EU policies. So thank you very much, Marion.
Thank you very much. It's my pleasure to try to make it clear for you, and I thank the attendees for listening. So let's first start with my disclosures, and I have here also the outline of my presentation. I will tell you what is pulmonary hypertension, when to suspect it, how frequent the anomaly is, but how rare the disease can be, the remarkable orphan drug development, and still the high mortality of the disease, the knowledge dissemination, how we do that with guidelines and with world symposia, the national policies versus the EU policies, and some key messages and action points. So what is pulmonary hypertension? You see the disease started with on the left side when the vessels of the lung circulation are open and progressively closing when you move to the right side. And you can see also on the heart, which is in the lower part of the slide, that when the vessels are disappearing, the heart on the right side is dilating, hypertrophic, and has difficulty to pump the blood, and that's why we have some trouble with the disease. How does it start on the patient side? It's being short of breath when you do stairs, progressively fatigue, and then you see some of our patients have blue lips, and you remember the Blue Lips campaign of Pha Europe with some of our well-known politicians, Minister of Health and First Minister who participated to the campaign. And when the disease is progressing, you have right heart failure with swelling legs, swelling liver, and also swelling neck vessels, and finally the heart give up. So pulmonary hypertension is a frequent anomaly which is found in about 1% of the population, and we have a very frequent groups, group 2, group 3, when it is related to heart and lung disease, but we have also among them some forms who are rare. And I will concentrate on the first one, which is pulmonary arterial hypertension, which is a prevalence of 50 per million, which is well under the definition of the rare disease, which is 1 on 2,000, so 10 times more rare than the definition. And even if it is rare, we had a remarkable drug developments during the last 25 years. You see in green the endothelin receptor antagonist, the PDE5 inhibitors, and also the prostanoids. And you can see that from 2004 to 2014, there has been no change in the pathway we are targeting when we treat patients. So we have a 3-way, and still we have not yet had something more since the last 10 years. Even if we have a lot of drug discovery and education in this disease, it remains a devastating condition. And you see the survival curve, which started with the blues in the 19s, and then in the 2000s, the red, and then later on the green points. So you see that we still have 10% mortality per year in the population with the current treatment. So we are looking to other ways to target not only to open the vessels by relaxing the muscles in the vessels, but also preventing this growth of the cells in the middle of the vessels. And we had a lot of trials which tried to decrease this proliferation, and we have at this stage only one which succeeded. All the red boxes are studies who failed. So we have some hope that we will be able to do that in the future. Now we also are caring for educations, and the knowledge is disseminated through guidelines and statements. It started in 2004 in the European Society of Cardiology, and then 2009, and every 5 years we have a new one, which is now a collaboration between the European Society of Cardiology and the European Respiratory Society. There are also statements which target more specific aspects of the disease, the pulmonary hemodynamics during exercise, which we will hear more on that, the rehabilitation in patients with PH, and also the chronic thromboembolic hypertension, and we have new guidelines which will be released this year. Now, this knowledge is disseminated by our pharma companies, but also by the World Symposium on Pulmonary Hypertension, where you can see it started in 1973 at the initiative of the World Health Organization, and then was repeated around every 5 years, with a number of attendees in red, which increased up to 2,500, and you see the crowded room in the Congress Center in Nice we had in 2018, and there is a new one in preparation. So many people are interested by the disease. Now, we also care on the organization of the care, and we are very interested, we were very interested by the development around the rare disease policies. And you know that Europe asked each individual country to have a rare disease plan, and France was well ahead of everybody, gives the example to everybody. You see Belgium, for example, is one of the last one. So in 2016, Europe also started with the European Reference Network, which we will discuss later on. But one of the problems, and this is your RODI statement, that it is the implementation, integration of the ERN structure into the national health systems. And so France, for example, as I said, was one of the first with the best example of a good organization around rare disease, and we have here the Réseau Français de l'Hypertension Pulmonaire, which was really an example of how you can organize a country around lung disease. UK is not part of Europe anymore, but has also very dedicated centers and is doing a yearly audit on the quality and the structure of the care, which is very interesting. Now, coming back to the ERNs, we have, so in the ERN lung, we have a group, a domain, which is pulmonary hypertension. And in this domain, we have 27 full members, which are dispersed, as you can see here. We have 4 affiliated partners who don't have the number to be a full member, and we have still the 4 UK supporting partners. Now, we have also tried to embed the research of this European Reference Network into a clinical research collaboration within the European Respiratory Society, and this is now starting within the coming years. So my key message are that the disease is rare. The prevalence average 50 cases per million inhabitants. There have been 14 agents approved in the last 25 years. The median survival is still only 6 years. And in Europe, we have very diverse care organization. Many countries are not yet organized for rare disease. They have a plan, but they have not implemented it. And there is a recognition in some countries, but in others, an ignorance of the expertise of the centers. And what are the action points? So we think that there is need for a strong EU incentive for and a control of the implementation of the national rare disease plans, including a clear identification and financing of dedicated expert centers, improve rare disease care organization, and also audits of these organizations. Of course, there is need of expedited new drugs approved and reimbursement, and we hope we will need that when we have these first anti-proliferative drugs available. And that needs, of course, a closer collaboration between the EMA and the EU member states. We also are working more effective incentives on rare disease research not restricted as it is frequently to genetic disease, but also to rare disease who have not a genetic background. And also we want to have it embedded in the EU scientific societies. Finally, concerning the ARNs, we think that there is neither less administrative burden, more transparency, more coordinated actions between the different ARN. We're also wishing to have global solution concerning registries, data sharing, regulation, because now all the ARNs are working independently and having their own development. And finally, we're considering the funding structure, which should be more, and I think, project-driven and less administrative costs paid for. Thank you for your attention.
Thank you. Thank you very much. Thank you very much, Marion, for a perfect introduction and a broad vision on the problem we are facing with the patient and all the stakeholders. So you mentioned ERN, and of course I would like to warmly thank Thomas Wagner, Professor Wagner, from Frankfurt, who is the chairman of the ERN Lung, and who has made a lot for the event today. So it's a perfect transition for the next speaker with, I think, Dr. Jose Valverde, who is Policy Officer, European Reference Network and Digital Health at the Directorate General for Health and Food Safety. So it's fantastic to have you around the table to discuss the role of the European Commission in the field of health and the EU health program. So thank you very much for your presence and for your presentation.
I think I'll go there.
Oh, you go there?
As you were saying, it's easier, and at least I have a chance to see my own slides. So I think you can leave it there.
Thank you.
It will work. So, well, thank you very much for the invitation, for the possibility to present here and give you a few. Many already know how ERNs are evolving, but the first thing I would like to say is I am working in the unit that implements the programs that support the ERNs. The strategies and policies are usually in the Directorate C in Luxembourg. So please make these 2 points. We are, let's say, the implementers, the ones that try to get the funding, the support programs and this.
That's why you are here.
Thanks. Well, this is how it looks now, a map with all the different centers. Please take into account it's 24 networks working in all the diseases, in all rare diseases. We are not covering all of them. We are not covering all the countries, but it has been a major effort in the last 5 years. First, to put them in place, and second, last year, to complete the geographical cover. This is what has been done till now. You know, from the directive in 2011, we were given the possibility to create these networks. This was a very important step that was built on previous efforts. Then in 2017, the first 24 networks went alive. And that was a major step in trying to work together across Europe and also with associate member states. That's very important. We tend to forget, and we think that they have been always there forever, but they were just running, started to run at that time. And also, please, many of the networks were at different stages of consolidation. Some of them have never worked together. So we have to give all of them the chance and the opportunities and the funding to start running and working together. But we have now established framework, we have a legal framework for it. Maybe it can be better accomplished for certain things as research and things like that, but the member states are working on that. The enlargement I was telling you is, it has been a very important step. We have now almost 1,600 healthcare units working across Europe in different networks. This is because at the beginning we had, in the second round, 843 applications. In the process of assessing it, more than 200 were left outside because of the quality and the really checking of the expertise in the different units. And it was mainly the networks that were saying who were the right clinical units that should go into it. So after the scrutinizing by the audit we put in place through an independent evaluation body, independent assessment body, we got 620 new members, plus 846 old full members, plus you have, this is the full member now, but we have also the affiliated partners that you were mentioning before. So all in all, there is a lot of units that across Europe. Now our calculations are 88% of the coverage, geographical coverage has been achieved. This is still missing something. All countries have come into the group, because before not all countries were in the year ends, and this is very important. And some of the countries that are smaller or have not such a possibility of having expert centers for everything, like Malta and these small countries, they are organizing national hubs, and this is very important because through those national hubs, any rare disease patient can go into the system. And of course, it's not only the 27 member states, it's also the associated countries that can be there. Norway is there, very present, and this is regulated by a board of member states, where every 6 months they meet and make the appropriate continuation of policies. So funding, that was the other question. You have to know that in the EU for Health program right now, the year ends are there, are in the program. They are mentioned, it's split, so the funding is there for them. Another thing is, many things for you to also know, that Europe is deciding to do at the same time. And I'm not saying anything in special, but you know that the health emergency authority has to be also created from scratch. And so there are different things, and from our side, what we have to do is to keep those funds very well assured into the networks. But, as I told you, the best advantage we have is that they are there. And now we have multi-annual grants. So we have prepared transitioning grants from the previous funding that was, as you said, crazy, coming from the CEF, coming from registries, from research, from different funds. Now it's only one grant that we will go directly to each year end, and then you can organize as you want. In August next year, we will introduce what is called finance not linked to cost. So that is even better. We will share which have to be the results of the networks, and you will get the money, basically, and then at the end you tell us what are the results. So it's much more sensible in the sense that you are not going to consume the money you have for the network on other things, on managerial things, but use it on clinical, on educational, on training, on these things. So this is what I was explaining, the different fundings that were coming in from the past. This bridge direct grant that has been an effort for the year ends and also for the Commission, because the EU for Health program, you know, always the first year takes longer to put in place, but finally what should have been done in one whole year has been done in 6 months, basically. And these new consolidated grants, I hope, until the end of the program, will solve the situation. So until 27 year ends are in the program, for sure. This is the characteristics you have in the, I don't think you will know, it will be 18 months, 100% of it will cost, no more sharing. Second is, well, we have been running the networks 5 years, but we have been putting public money into this year ends. We need to know what has been working, what needs to be improved, and what lessons can be learned from each of the year ends. So basically, and not as an audit system, but rather what I like to call a quality improvement system, really. We are trying to see how we can get better from the administrative point of view, from the implementation side, but also from the clinical side. The demands of urologists, of the patients, of the representatives is, you are there for 5 years. What has changed in this time? So we want to see also what is not only the quantitative, but the qualitative part. What has changed in the ecosystem in Europe with the ERNs. So we are going to use the initial assessment results, we are going to use the continuous monitoring of every year, and we are going to do an evaluation that is by law obliged, that we are obliged to do. So this evaluation will start after the summer this year, and in a year we will have the first results. Results per hospital, results per ERN, and results of the whole ERN ecosystem. So this is what I was explaining. I'm running out of time. This is more or less the time scale. And finally, future actions, because I think these are very interesting. The CPMS is the tool that allows us to make teleconsultations between countries with many experts. We have had many criticisms about the first CPMS model. It was too complicated, it was difficult to fill in, difficult for the users, difficult to introduce experts. So we are preparing already a new CPMS that will try to avoid all that and will be all even in the apps. And the member states will have the open source of this development. So if they want to make one at their level, in their own language, it will be possible also. That's another point which is linked to the joint action on integration in the national healthcare systems, which has just been published a few months ago. The EU Academy, and theoretically at the beginning was the ERN Academy, but we are obliged in EU, in the Commission, to work with the tools we have already. So what we are going to do is to put all the contents, the trainings, and the handbooks that are being created in this EU Academy for being accessible to everyone, to any citizen in Europe. No longer for the patients on rare diseases, no, for everyone that can be used. So there will not be this limit to what training can get patients or patients' relatives. The continuous training, so we work on guidelines. Different ERNs have different levels of development. They know how to do, and they are working since a long time with societies to do this, but we try also to support the ones that have had not this possibility. So we have been working on creating handbooks for the introduction, the real introduction of the patient's perspectives on these guidelines, on the development of the guidelines, but also on the different tools that you can produce for making decisions. The mobility program is in place, and it is, even with the COVID, it has been stopped for some time, but now it's running again, and it's moving people around Europe, specialists from one place to another, and now patient representatives have also the opportunity to use it, and project managers in the years. We can speak later if you want about the research, the registries, and the European Health Data Space, but I would prefer to make no comments today because it's going to be published in days. and this is an address especially to you that have contacts at the level of the member states. The joint action has been published. The letter to the member states is there. This is a joint action. This is an opportunity. There is plenty of budget for this joint action for the next year for all the member states. The letter is on the ministers now through the permanent representations. It's the moment until September to decide which is the organization or organizations that are going to take part. This is the opportunity to create the national pathways, to create the links inside the countries, to see the best practices from France, from Spain, from Germany, from Austria, from different countries, how they are doing, how the Nordics are doing, how other people. And there is not only money to make paperwork, to make PERS research, there is also money to start your own national hubs and the organizations that can do it. So it's a big opportunity, and it has been put by the Parliament also and by the Council saying, please, you have been asking for this national integration, now do it. So it's in the hands of the member states and the organizations and you as representatives, and to tell them this is important. There is not the only action in joint action in health. There are also another 9. So there is a little bit of competition between these. So as representatives of rare diseases, I ask you to please push for it. Thank you very much.
Thank you very much, Dr. Valverde, for a very stimulating presentation, a lot of concrete information, and thank you for implementing these ERNs into reality, because we believe in it, and we think it's a very useful tool, very useful instrument to deliver better care to the patients. So thank you for that. So we hand over now to the Patient Association. So I would like to warmly thank Gergely Messaros, who is the project manager of Pulmonary Hypertension Association Europe, PHA Europe. And the call of action, which is disseminated now, is truly important. And Gergely is going to introduce the call to action position paper, which has the keyword patient empowerment. So please, Gergely, the floor is yours.
Many thanks, Mark, for the kind introduction. Good morning to everybody, and it is my pleasure to welcome those who are following us on Facebook. Please use our Slido. We made a special tool so you can raise questions through the internet, and we are trying to answer within the Q&A session. Previously, we learned about ERNs and also some of the basics of pulmonary hypertension, but let me position our call to action paper. Each and all association and organization needs to have a clear strategy and pathway what to be followed. 10 years ago, we launched our original paper here in the European Parliament. So it was high time to revisit this paper to see whether those goals are still relevant, whether some of the objectives need more attention and more support and focus. In 2020, we tried to start this work, however, COVID stopped everything. But in 2021, we successfully launched Roundtable. This consists of medical review committee, as well as I'm happy to let you know that all the stakeholders on the pulmonary hypertension are there. So we have patient representatives from Canada to India, from the United States to UK and Europe. We also have representatives from the regulatory bodies and representatives from the pharmaceutical companies. As a result of this big work and lots of hours of drafting, we managed to finalize our new paper, Call to Action. I can say it's a very freshly looking modern paper. We put special emphasis on visuals due to multiple purposes. One of the purposes was to shrink a little bit this paper. As you might know, once you are revisiting a paper, it is always longer than the previous one. We managed to make with these visuals a shorter paper, but more precise one. There's also a goal for this to attract attention, because we know that not only rare disease phases and fields, but the healthcare is also very busy, so we need to be very attractive. That was also another purpose with these new visuals. And last but not least, these visuals can be used as standalone communications within brochures, and also emphasize the importance of the lists we have on these visuals. But you might ask what we kept from the previous paper. We kept the pillars we are building on. So we have 5 main pillars we are working on. One of them is access to treatment and centers, patient and patient association improvement, psychosocial support, increase empowerment, improve awareness and screening, and also clinical research and innovation is our key focus. But I need to admit that we have heavily rewritten our previous paper. You can see some of the pages I put on this, so it was a huge amount of work. Let me briefly introduce you the patient empowerment part of this paper. Previously, you might have heard about patient participation, patient involvement. However, WHO provided us a very comprehensive definition of patient involvement, which say that actually it's a process where people gain more control over the decisions which have impact on their health. You might think that it has two levels, an individual level and also on a society level. I put components of the patient involvement on this slide. I think it's obvious to say that if you do not have as patient the patient's skills, you do not understand your position, and you do not have the supporting environment, it is not possible to talk about patient involvement. But we know that we need involved patients who can talk about their condition. We know that there is a big need of patients and patient representatives who can talk about this disease and participate in shared decision making. There's also an important part of patient involvement. It is health literacy. There are lots of papers published regarding health literacy, and the common message of this paper was that once we have higher health literacy, we have better adherence to medication. Those people are reporting less chronic diseases. They are doing better, and ultimately, they have better quality of life. Quality of life can be understood both on individual and on social level. And here comes the role of the patient association, because we can talk about empowered patient associations who are really helping patients to be empowered. It is a must that we need to facilitate real-life information exchanges between patient association and other stakeholders. I'm really happy to let you know that once we are looking back to the past decades, we have achieved lots of results and achievements. We were participating in reviewing guidelines and statements. We were part of many discussions in trial medical boards. We also participated in regulatory discussion regarding health technology assessment. And also, we organized lots of advocacy activities and very active part in ERM. Also, there is a close collaboration with scientific committees like European Respiratory Society, European Society of Cardiology, and we also have links to the Pulmonary Vascular Research Institute. As I said, we achieved lots of results. However, I need to stress that policymakers and decision makers at all levels, from the very beginning, needs to involve patient associations, PH patient associations, once there is any discussion or whether there is any decision to be taken which might have impact on the life of patients living with pulmonary hypertension. I need to admit that we haven't discussed previously with MEP István Újhelyi, but I have a specific slide which is addressing his very specific request. It is about a special role what patient association needs to play. It is a special bridging function between the medical society and the patients to translate, to process those information which we have on the medical side to the patients to be understandable on a lay level. How we can achieve it? What we see in the pandemic, that there's a huge interest and need towards to reliable and up-to-date information. We need to have new brochures. We need to have webinars which are addressed to patients to better understand their condition. I'm really happy to let you know that some years ago, Pha Europe launched a special program which is helping our members to make new web pages for them, which can be a very good repository of such kind of reliable and up-to-date information. But lots of work needed at this point as well. Last but not least, let me stress this point as well, and I see that most of us are really talking about funding. It was also Jose who addressed this on this topic on his last slide. Without having appropriate funds for patient association, it is not possible to make their own work. What we see is that we have almost 10 years with this call to action. If we do not have diversified funds, if we do not have long-term commitments from our sponsors, it is not possible to make such kind of work. It's like hurrying and catching all the things without special focus on the pathway we would like to follow. I also would like to stress that the government should step in and somehow support patient association. We know some countries that it's possible to offer the percentage of the personal income tax for non-governmental association and organization. This is the case, for instance, in Hungary as well. I think that is a very good practice, which is also followed by Italy, which ensure appropriate funds for patient association. Also, another source should be for patient association to be able to participate in various EU funds and calls. We know it's very difficult for them to be eligible to apply for such kind of funds. But I can assure you that many associations would dare to apply for these funds if there's a possibility for them. Not only as a sole player, but with collaboration with other scientific societies or from the medical sphere. We learned that it is worth investing into healthcare because it results in quality of life. We also learned that patient associations are really good tool for this. There was a new paper just released in 2021 that those PH patients, it was a special PH patient paper, those PH patients who are participating in patient groups and patient association reported better quality of life. It's a clear message that we need patient association. It's a clear message that we need to support PH associations. So please support us so we can help patients living with pulmonary hypertension. Many thanks for your attention.
Thank you very much, Gergely, for making it very clear, and I think we heard your message, and we will have time during the panel discussion to address many of your very, very clear statements. And without more discussion, I hand over now to Laurent Godinas, who is a medical doctor and associate professor at the University of Leuven, and he's going to discuss one of your pillars, Gergely, improve screening and raising awareness. So please, Laurent, you have 5 minutes to address this difficult task, but it's very important.
Thank you very much for the opportunity to be invited today as an honorary career member in this task force. So I will talk about screening and awareness in pulmonary hypertension. As told us more than 2,000 years ago, the philosopher Sophocles, look and you will find it, what is unsought will go undetected. It's nowadays still true, and especially for rare disease. And it has been translated in medical school by we find what we look for and we look for what we know. So we find it's the diagnosis, we look for is the screening, and what we know is awareness. So to have a good diagnosis, we have to be aware of the disease and we have to screen for it. But it's not only a philosophical matter, it's also the reality for PH patients. We have to perform an early diagnostic because we know that the diagnosis for PH is still too long. In this study, most of half of the patients were diagnosed more than 3 years after the onset of the symptoms. It's very long, and most of the patients had several appointments with medical doctors, had received sometimes wrong medication with wrong diagnosis, and after 4 years, the patient received white catheterization, the good diagnostic, and it's required only 1 day to start an efficacious treatment. So it's more than 3 years to diagnosis and just 1 day to treat the patient. And it's really important to start early the treatment because we know that early diagnosis in PH may improve outcomes. And it has been demonstrated in clinical study. If you treat patients with mild symptoms, so at the early beginning of the disease, you can improve outcomes. And how can we make the diagnosis earlier? It's with screening of patients. And who has to be screened? For PAH, there are several conditions associated with PAH, and we can screen PAH in those patients. It's, for example, genetic component, connective tissue disease, liver disease, HIV, congenital heart disease, and toxic exposure. But there is also other subgroup of patients with chronic thromboembolic pulmonary hypertension, and they are prone to develop PAH after pulmonary embolism. So we have to follow and screen patients after an acute event, after an acute pulmonary embolism. There are also other conditions such as venous device, hematological condition, inflammatory disease, and it's really important to diagnose CTEPH because we can cure this type of PH. And it's also really important to think about PH in patients with persistent and unexplained shortness of breath. And it's really important for the first line of healthcare professional, for GP, to think about PH in some kind of patient. And those screening work, there are some studies about screening. I just showed one recent study about screening in patients with genetic predisposition for PH. And so in this study, the author have looked at the genetic mutation in some relatives, so not in patients, but in relatives of patients with irritable pulmonary arterial hypertension. They have screened the patient for genetic test and also for the disease. And with a very complex algorithm, they were able to diagnose some patients at a very early stage of the disease. So with complex algorithms, with sometimes here genetic tests, we can do a diagnosis very early in the disease and potentially improve the prognosis of the patient. And how can we improve the recognition of PH? There are different levels, and first there is medical education. The healthcare professional have to know about PH, but there are also awareness campaigns for general population. So medical education targets medical specialists, but also primary healthcare professional. Awareness campaign targets patients at risk for PH. It's important for them to know that they can develop PH, but also general population. It's obviously not mutually exclusive, and medical education is also for the patient, and awareness is also for the healthcare professional. And there are different stakeholders in awareness. There are medical schools, scientific organizations, public policies, and patient associations, and we have to work together to improve awareness. And until now, what is the biggest achievement for awareness? It's, as I already mentioned, the World PH Day since more than 10 years now, on the 5th of May. And the aim of the World PH Day is to increase awareness and understanding of the disease to promote early diagnosis, which is really important. So what can we do to help the patient, the PH patient, and to support the PH community? It's to initiate PH awareness campaign for both professional and public, to create training program on PH for healthcare professionals. It's really important. To create national screening and diagnosis program, and also a very specific program tailored to PH patient subgroups, because they are sometimes really different. And to raise awareness of the potential for curative treatment for chronic thromboembolic pulmonary hypertension and the need to appropriately screen and evaluate this kind of patient. Thank you very much.
Thank you very much, Laurent, for showing us good examples on how to, and this is a pillar of the call to action, and you have showed us that it is feasible, and we'll discuss further that later. So now, another pillar, access to treatment. So important. So Adam Towicki from the Center for Postgraduate Medical Education from Oxford in Poland. Thank you very much.
Mark. Thank you very much. It's a great privilege to contribute to this meeting, which I'm sure will open a new era because we can collaborate better, can understand better our positions. And I think it's a great idea to meet here today. So access to treatment, it's of course crucial for patients with progressive forms of pulmonary hypertension. I would call that, in this way, patients with pulmonary arterial and chronic thromboembolic pulmonary hypertension. its main determinants, two of them are obvious. One is awareness, we just heard about it, and the other is local availability of medical and interventional therapies. Probably somewhat overlooked is the middle element, which is reliable and fast differential diagnosis. If you look at the diagnostic algorithm, which should identify patients with progressive forms of pulmonary hypertension, you see how complex it is. At the end is the PH expert center with extremely important role of making final diagnosis and starting the correct treatment. But it will not deal with thousands of patients with suspected or even confirmed pulmonary hypertension without the help of whole healthcare system, because the whole health system has to identify early those patients with high probability of progressive forms of pulmonary hypertension and allow for a fast track of those patients to expert centers directly. Another role of this whole healthcare system is to eliminate patients with common causes of pulmonary hypertension, which do not need to reach expert center because they don't need specific treatment. This specific treatment for PH may even be harmful for those patients. So reference expert centers need help from the healthcare system, but also it can provide help. And this is something that is recommended by our ERM lung. Simple telemedicine system, which at the present time is called EXABO, Expert Advisory Board Online Consultation System, which allows to pre-triage patients which should go directly to expert centers and who can be diverted back either to other ERM, because this might be some other rare disease, or to general healthcare system. So this is important, but it is not perceived as important by healthcare providers, by hospitals. It is not reimbursed. It takes a lot of time. It detracts experts from their patients. So this should be, in a way, perceived by the system and financed by the system. Another important tool, and I'm very happy to hear what Dr. Valverde told us today, is this internationally accessible, very sophisticated consultation platform for difficult, complex cases of patients with pulmonary hypertension, to reach the diagnosis, but also to decide on correct treatment. The problem with CPMS, apart from the fact that it is at the moment quite difficult to use, is that it was accessible only to members of the ERM society. You have here as red diamonds these members that could benefit of this cross-border consultations. The smaller countries with smaller populations were not able to reach the competency requirements and most of all the number of patients seen each year in their centers. So this is a limitation, and the smaller centers need to access this consultation platform a lot, because they have less experience. This is also seen that this experience is important to develop some of the more complicated forms of therapy. And if you look at the availability of surgical treatment of chronic thromboembolic pulmonary hypertension, you see that smaller countries are referring their patients for surgery to other centers, larger centers abroad. And this should be facilitated. Of course, there are some mechanisms within the European Union that supports it, but this is almost a must for those centers. And those are also PH centers, but they do not reach the criteria of ERM centers. So this should be automatically almost supported, that those patients can reach easily centers that provide this service. This also refers in some part to balloon pulmonary angioplasty. Not only surgery and angioplasty are complex, also medical therapy for pulmonary arterial hypertension may be complex when it is delivered by continuous intravenous infusion to the large veins and this must be done 24 hours a day, 7 days a week. If it stops for some reason, you need to respond immediately. This also creates some costs because this type of treatment usually is up-titrated, so you cannot predict the cost which will be needed for a single patient up front. What's more, those therapies are lifelong. Once you start it, you treat the patient as long as he is alive. And there is a paradox, because the more effective you are, the more cost this requires. Similar things as with CTEP. I will not go into details, we don't have much time, but for all these reasons, payers in various countries are not very eager to follow the state-of-the-art treatment recommendations very easily. You have here an example from Poland. Sometimes it takes 2 years, sometimes it takes 3 years, sometimes it takes 5 years to change the strategy of reimbursement so that it matches the current state-of-the-art requirements and recommendations. We don't know exactly which countries are in what place regarding this matching the needs of the patients. There are two important now actions. One is Pha, which has been already mentioned. The other one is the activity of Pulmonary Vascular Research Institute, which looks not only into Europe, but also tries to understand the needs and position of this reimbursement strategy in developing countries. So my final slides and challenges for the future are summarized here. We need support for this early telemedical triage so that right patients get quickly to the expert centers. We need broader access to this consultation platform, not only for ERM members. And finally, we need some pressure, and maybe this in what we've heard about more integration within ERM with National Healthcare Service will help to push some stress, to exert some stress on local payers in order to give immediate access to validated and new therapies for PAH and CTEP, because the delays in this therapy results in irreversible changes in quality of life and survival. And finally, even with all our efforts, some of the patients cannot be treated effectively and successfully, and they need lung transplantation, and this also should be perceived by us in terms of easy and early listing to the centers and close collaboration of those centers with us. Thank you very much.
Thank you.
Thank you very much, Adam, for making it very clear that access to treatment is a priority. It's not only medical treatment, it's also all the strategies, and we should have an equity all over Europe for these patients. So clinical research and innovation is linked to what we just heard. It's a pillar of the call to action. And I'm delighted to introduce Professor Gabor Kovacs from the University of Graz in Austria, who is going to present how to encourage clinical research and innovation.
Thank you very much, Gabor. Thank you very much, Mark, for your kind introduction. Dear colleagues, dear friends, ladies and gentlemen, it's a privilege and a pleasure for me to be here. And I just remember an hour ago, maybe we were discussing in front of this beautiful building on the relationship between politics and medicine, and I think you will all agree that this is a great example when we can mutually support each other and we can reach good things for our patients, where the patients are really in the focus and we are trying to do our best from both the politics sides and also from the medical side, and I'm very thankful to you and very privileged to be part of this. And if I may also add a personal statement to that, you said that both your parents were doctors and you didn't understand much from the conversations. When you were saying that, I was almost laughing because I had the same when I was a young boy. both my parents are doctors, and they were discussing sometimes clinical cases. And as a young child, I tried to use the same words, mocking my parents, but I did not have the courage to do something else as you did. So I became a doctor myself.
And I'm a politician.
So my topic is now in these 10 minutes is clinical research and innovation, and probably all of you will agree that this is a very, very important pillar. And I'm showing to you this first slide where I tried to show you the basis. And I think this is very unique in the history of medicine, that in 20 years so much has been done for a rare disease. And I think this is a perfect basis for future development. We have a lot of new medications that have been developed in these years. I think the cooperation between the industry and the community has been really, really great. And now, with your support, I think we have a good basis to have further steps in this direction. And Gergely, you mentioned that we had to rewrite most of the text of this little book, and I think this also shows how much has been done in our field in the last 10 years. So in this little booklet you will find some important topics we are discussing, and I would like to show you a few of them. And first of all, I would like to show you something on the therapy, on the current therapy opportunities. And as I showed, a lot has been done here in the last 20 years, but it is still a long way to go. We still are not able to cure the disease in many cases. We still need to have improved opportunities for some classes of the disease. So there is really a lot to do with a common effort. So first of all, I would like to address the topic clinical trials in PH subtypes other than PAH. You have heard in the talk of Marion Delcroix that we have different subtypes of the disease of pulmonary hypertension. We have pulmonary arterial hypertension. You also heard of chronic thromboembolic pulmonary hypertension. However, there are also other subtypes like pulmonary hypertension in lung disease and in heart disease, which are more frequent, but where we did not have any opportunities to therapy these patients. And now in recent years there are big developments. I'm just showing to you one of the recent studies, which was the first one to have a positive study to address pulmonary hypertension due to lung disease or pulmonary hypertension associated to lung diseases. And we are getting to understand much better now which are the patients who can profit from a specific treatment, and we are looking forward to further studies in the next years, and we hope that we will be able to offer effective medications for many patients. Of course, more research and more innovation is needed for this. Then a very, very important topic is quality of life. And I think if you look at the guidelines, if you look at the proceedings of the World Conferences, in recent years you will find that we are increasingly addressing this question, what is important for the patients? And the top of this pyramid are parameters that are important for doctors. How good is survival? Of course, it's also important for patients. But they are endpoints that we addressed until now, which the doctors define. And now we are moving into an era where we are more and more aware what are the quality of life assessments, what are the important factors for our patients, and we are addressing more sociological support, spiritual support, palliative care, social support of our patients. And also in the daily practice, when we are talking to our patients, we are using more and more shared decision making, so that together with our patients we are coming to treatment goals and management goals. We have different goals maybe with a very young patient, and we have different goals with elderly patients with multimorbidities. So I think this is highly relevant and important. Of course, more clinical research is needed. Also here we have to understand each other even better and work on this together. This is a special slide to me because it was done in our center and I found it very interesting at that time. Also it was mentioned that the clinical diagnosis of pulmonary hypertension is made by an invasive measurement or right heart catheterization. And although this is an investigation which in experienced hands the complication rate is very, very low, nevertheless we are still working on different innovative tools which may be able to help us to avoid right heart catheterizations. And this is one way to go. This is cardiac MRI, magnetic resonance imaging, where we were able to visualize, but there are also, of course, studies from other centers, that the blood flow in the pulmonary artery in patients with pulmonary hypertension is doing a vortex. So it's not flowing gently like in patients without pulmonary hypertension or in healthy subjects, but it's turning around and making the vortex. And in this study, that was possible to correlate the mean pulmonary arterial pressure, which is a key hemodynamic parameter for us, with the existence of this vortex. And this is one opportunity to follow a path where maybe we will be able in the future to avoid right heart catheterization in many cases, which is again very important for our patients. Artificial intelligence and machine learning are phrases that we hear more and more in the last years, and also in our field, in the field of pulmonary hypertension, they are taking a more and more important role. And we have here different technologies. We have artificial intelligence, machine learning, deep learning, where we begin to understand better and better how it works and how the machines can aid us to have earlier diagnosis and optimal therapy for our patients. And this is only an example from Sheffield, from an important center in Europe, where they are working with these techniques on a very high and developed level, that CT images of the lung can be investigated by machine learning techniques so that signs of pulmonary hypertension can be recognized and can also be used for screening. So these are novel technologies which are surely to come in the next years. And finally, international collaborations. I think this is of great importance. And also Marion mentioned the statement of the European Respiratory Society on pulmonary hemodynamics during exercise, which is a statement where we tried to summarize the knowledge on this field. We are not only interested in what happens at rest, because most of our patients have symptoms, have problems during exercise, so we also would like to understand what happens in the lung vasculature during exercise. And now this is a great collaboration. One of the leading centers is Paris, where Professor Ambert is working, but also many other colleagues are involved here. Altogether 30 centers from the world, and we have collected the data already of 1,500 patients all over with very elaborate right heart catheterization during exercise and clinical data. And I think this is a good example how we can collaborate together, where one center would never be enough to have sufficient data to understand important physiological and pathophysiological mechanisms, but together I'm sure that we will be soon able to have important messages in the field. So with that, I hope I could give you a short overview on the most important points of research and innovation, and I'm looking forward to the future together with you. Thank you very much.
Thank you very much, Gabor, for once again a very good presentation, which will really help us for the panel discussion in a few minutes. So now it's my great pleasure, great privilege to welcome the PHA Europe President. So this is Eva Otter. We heard very well from Gergely that psychosocial support is a mandatory pillar of your organization, and your voice is very important. So please let us know how we can develop further this support and how we can partner with you on that level.
Thank you very much for your good words. Thank you for the invitation, and special thanks to Gergely for planning this great event. And thank you to all of you for the renewal of our call to action, all the efforts you have done. So, yes. Now, my position in PH Austria is Vice President, and you heard I'm President of PH Europe since January this year for a 2-year term. So my topic is the psychosocial support. It's a big challenge, as I'm a patient too. I know the problems and the challenges PH patients face, and I want to talk with you about the patient's perspective. So what is important for patients? Most important is an access to a good medical care system. What includes this, PH center, PH hospital, and the connecting to your doctor at home. Also a good relationship to your PH doctor and to trust your doctor. So as I do, you can see it on the picture. To get a diagnosis is very important. Also treatment with various medications, not only for 1 or 2 medications. And this, my wish is all PH patients all over the world should have the possibility to get all medication they need. Rehabilitation during your stay in a rehabilitation center, this is very important because you learn how to breathe, you learn how to walk, how long you can walk, how to use oxygen, and so on. Caregivers, not to forget our caregivers, they're always around us and help us. And the PH associations, and last but not least, the psychosocial support. So, the psychosocial support, to consult a psychologist, for whom it is important. For patients, but not to forget the relatives. They are always with the patients, and when you have a partner with a diagnosis for incurable disease, life is changing, believe me. Not to forget our caregivers and friends and colleagues. Some of patients still go to work and they talk about their disease, but you cannot see the disease. And this is very, very difficult to understand your disease. And to talk with friends, because as patients can talk with friends, drink a cup of coffee could have a relaxing effect for patients. And the patient associations. So how can help patient associations? Patient associations are a helping hand for the patients. They keep patients informed and guide them. We plan patient information days, also peer-to-peer meetings for patients. During an information day, you can have a one-to-one talk to your doctor. It's very important. They can share their experience with other patients. And then they will be informed about the new medication and how the medication works. So to train patients, accept their illness. To accept the illness is a very long way. So, and to increase self-esteem. We have seen during the pandemic, this is a very big topic, to increase the self-esteem. I am what I am, with PH or without PH. And to educate them that they are doing all the efforts they have to do for themselves to get a better quality of life. So to need your medication always in the right time, to take care of you, and to contact to other patients. So we have seen in a peer-to-peer meeting to contact, to meet patients, like-minded persons. It is very important because you can share your experience about your medication, about your disease. You can talk about other topics like how to live at home and so on. And confidence to ask the PH doctor all questions during checkup. When you have a good relationship to your doctor, You can ask all questions about your disease, and this is very, very good for patients. And the social issues. The social issues is a big topic in our organization because we help patients to get care money. We help patients to get passport for reduced mobility, or to fill in forms and to contact the correct department, and to teach them how to let your body rest and to let rest your soul. This is very, very good. So there is an international study which shows us patients, they are members of a patient association, are confident in self-care, can understand better their treatment, or when they have a right heart cath, they know why and have a better insight and so on. And they have more quality of life, and also the relatives, not to forget the relatives. So, but what's the work behind the scenes? This is the work patients cannot see, but patients can see the results. It's the networking with doctors, caregivers, study nurses, and so on. So we know how we can help the patient. To prepare papers is very important, not only to send them an email or to have all on the homepage, because we have elder patients and they cannot use internet. So we can prepare papers. So we do our newsletter called Arterial, means breathtaking. We have brochures about nutrition. We have brochures about what is pH. We have flyers and so on. And it's when the patient is calling me at the first time, I send them a little package with all the information we can give them, and then we can talk, and I can ask, what do you need? What do you want to tell me? So fight against isolation. Fight against isolation and be a link to solution providers is very important. And fundraising. We in Austria, we do fundraising. We have the Zoo Run, and we have the Zoo Run. Oh, Ghost Run. Ghost Run. Thank you. And we have the Ghost Run. And believe me, there are many, many moments with many funny moments during these events, and this is fundraising with fun. And we heard about awareness. Awareness is very important. This year we are getting closer to the 5th of May, our World PH Day, and this year is a special year because we have our 10th World PH Day. So what we have done is during the pandemic we maintain a 24/7 hotline, and believe me, many patients called me. And also we founded WhatsApp groups. These WhatsApp groups are also important because patients can share all what they want. They send pictures of themselves in the groups and so on. And what we have seen is it's very good to have psychologists and nutritionists in the team, because patients can get an appointment in a very quick way. And also the psychologists as a nutritionist know what pH is. And all what I told you, Professor Frank Draghi from Florida Cleveland Clinic summarized this in one sentence. HCPs are treating the patient with the help of drugs from the industry. Patient associations are taking care of the patient in their daily life, which is an important part of the disease management. What a statement. So my last slide, it's incredible how contagious positive energy can be. Many thanks for your attention.
Thank you very much, Eva. A lot of energy, very wise comments, and thank you for pushing hard for your patient community and at large also for all patients affected with rare diseases. So now it's time for panel discussion. I will keep an eye around the table. There are many people in the room, many stakeholders, people coming from the political side, the medical side, the pharma side, the patient side. It's quite important, coming from very far away. For some of you, thank you so much for flying all the way from Canada, for example. And I will maybe take the liberty to ask the first question. And I will watch on my right. If there are any questions coming from Facebook, you will let me know, because I'm not connected on this side. So before asking our host, Istvan Hui, to give us his feeling, maybe I will ask one question to Guerrier, and it will be a very simple one. How do you plan to use your call for action after the launch event? What are, let's say, don't make a long story, but what are your main action points? Maybe the word PhD, etc.
Thanks, Mark. I think it's a very important question once we have such kind of important paper. But we believe that it is not the end of our route, so it should be cascaded down to the member association. We are planning to translate the summary. We have an executive summary within this paper, and local activities, political activities are also planned to initiate further steps and actions in favor of the patients.
Thank you. Before handing over to our MEP host and our ERN supporter, maybe another question related to this one, because it's quite important. You mentioned funding on several occasions, and do you think there is an optimal structure of funding for patient association, or there are many ways to support, to give you independence and strength?
Yeah, that's a very tricky question, and I believe that that what patient association are need is a diversification of funds. So we know that it is very difficult to have funds for overhead costs. Probably it's much more easier to receive funds for a specific project. But in order to run a patient association, you need to have a stabilized fund, which is not coming from one or two sponsors, but coming from a great variety of sponsors. So I think that is one of the most important things. Beside the one is that what is really needed is long-term commitment. So it is, I think it's a very big message from our end.
Yeah, you need some comfort to be able to foresee the future with enough security.
Exactly.
Thank you so much. Maybe a first comment from Istvan, and then we will discuss.
Yeah, thank you. I have 5 concrete points, but I would like to push, and of course, most of them was mentioned here. So we talked about the EU for Health program, and it should increase funding for European references networks, but we got it, and we understood very well how we can help it from the European Parliament. The European Research Council should prioritize rare disease. It's also important question. We have to push it. The HERA should also cover the unmet needs in rare diseases. And the Horizon Europe program should further support projects on interdisciplinary research in the area of rare disease. And one more thing, the upcoming revision of the EU rare disease pharma legislation will be crucial to advance progress in this area, but you mentioned it. So I hope that it's not only a roundtable discussion, but we can work on it. So thank you so much.
Thank you very much for these very clear statements and some action point we can partner together in order to deliver a true action. So maybe Dr. Valverde, you want to add something, because you made very clear points, and we are very happy to see concrete presentation on the ERN, and we are very, very fortunate to have an ERN line with a pulmonary hypertension core network. But there are other core networks. Everybody's working very hard. So Marion Delcroix made a presentation. She emphasized that ERN is present, but it is improvable. And do you think that with better funding, better long-term commitment, we can build something stronger together?
Microphone.
Microphone, yes.
Well, thank you. I think that there are still many aspects on the EFNs that need to be further developed. As I mentioned, we are working on with the 24, so with the whole community of rare disease patients across Europe. And each network has the necessities. Some people mentioned the geographical coverage. The solution for small states or with centers that have not the numbers that allow for clinical excellence is to get together into consortia or into national hubs. And for this, the joint action for the integration at the national level would be a very important tool, because like that they can create pathways inside the countries for referral, and then they will go to the ERNs or to the centers and can present through the CPMS or through the systems you have already in place. So of course, this is still, as we said, work under construction, but I think it has represented a real change, and hopefully in the future it will be more. That's the message.
Thank you very much. As Marion Delcroix said, in France we are quite fortunate to have the rare disease program as early as 2004, and it takes time. I mean, it takes time to build not only a network but also a relationship and understand modern life also, because from 2004 to 2022, I mean, life has changed so much. And I'm going to ask Marion, and maybe you can jump in if you wish. Can you tell me your opinion on the best way to partner with patient association in clinical research? Because the ERNs are patient-centric. I mean, that's something we should never forget. I mean, the patient cross-border care, good quality of care, equity all over Europe. You can be born in Greece, in Paris, in Brussels. You should be able to have access to best standard of care all over Europe. But regarding clinical research, do you have some ideas on how to partner with patient associations?
Well, I think we have already some examples, new studies starting with a patient's representative on board on the steering committee, and so looking at this specific aspect. We have collaborative research starting on CTEF with this model, and I think that should be just natural that you have a patient representative in the steering committee. I don't think the industry is doing that already. Perhaps for registry, but for big trials, yes?
Yeah, we have it. We have it, but it's growing. For example, patient-reported outcomes. We try to build and build and build, and in some studies, the primary endpoint is very patient-centric, and there is a patient representative which is sitting in the room. So, but it's emerging.
The speed of accepting patients that really need our help. So I think there is a future for telemedicine, both in terms of very simple consultations, but also in terms of well-designed and more human-friendly CPMS system. And I'm very happy to hear that this will be changed, because we really need it. You have done something like this in France for your needs. We have something in Poland, but to do it in the same standardized way, we need a good tool, and I'm looking forward to this promise.
Yeah, you often need multiple tries to get the right solution, and in France we had also a very, very highly protected CPMS system, and now finally, as you do, we have simplified it, and now it's very active and all over the country, and I'm sure it will be the same way for ERN CPMS. So maybe a question to Eva. Thank you very much for sharing with us a very clear statement on psychosocial support and quality of life. And you made it very clear that patients who are part of patient organization have a better, or at least a good quality of life. And that's, I think, a key message when you interview patients. Of course, they like to walk more, to have a more active life, but the feeling of doing better and understanding what's going on is very important. How can we help you more with all these quality of life support? And you mentioned rehabilitation. It's very difficult in many countries in Europe to have access to rehabilitation. So maybe that's something we could help and support. So you want maybe to say something on patient-reported outcomes and quality of life?
Now, for me, this work in the association is not only a work, it's a passion. And I try to help patients, I try to help them to cope better with their disease. And when patients see you have time, you talk with them, you can understand their problems. This is, you can help them very, very much only to listen their problems, yes? And rehabilitation is a big topic for my doctor, not for me. Sorry.
Your doctor is in the room.
Yes, yes. He knows this, he knows it. But many patients tell me they like to go to have a rehabilitation because they are fitter after a rehabilitation. They can walk longer, they can understand their disease better, all these tools. And this is so important because when you accept your illness, you have a better quality of life.
Yeah.
All the medication and all the other things.
Thank you very much. It's very important to hear, and thanks for what you do. Maybe another question to Gabor, because you are sitting next to your patient, and you have mentioned that you need to be a little bit invasive when you establish a diagnosis of hypertension, and many centers like mine are still invasive in the follow-up. So can we be less harmful or less difficult to our patients with new tools? You showed us a very nice picture with the vortex images, but echocardiography is also available and other mechanisms. Can you tell us if there is a brighter future for diagnosis and follow-up?
Thank you very much for this question, Mark. So I absolutely agree that currently we need the right heart catheterization, and this is, I think, an important statement that currently for the diagnosis of pulmonary hypertension, due to several reasons, I do not want to go into deep details now, but right heart catheterization is necessary and is important. It's important to clearly understand the pathophysiology of the disease. And in experienced hands, as I also mentioned, it is also an investigation with very, very few complications. So you do not have to be that much afraid of that investigation. But still, I agree, in the future we would be happy to offer other tools. And also currently are already many tools which are available for follow-up, so that we do not need to do right heart catheterization at each year, maybe for each patient that follow-up, because there are important non-invasive tools, including echocardiography, which allows us to estimate the pressure in the pulmonary arteries, but also the function of the heart. But we also have tools, laboratory tools or exercise tools, which help us to estimate how the risk of the patient is to progress with his disease. And if we see that the patient is in a low-risk category, he has a good chance to maintain a good health condition, then we can decide that it is not necessary to do a follow-up right heart catheterization, for example. And the second issue is very, very shortly, I mentioned cardiac MRI, but there is also CT, for example, and other tools which are very promising that in a few years they may be so far that they can really be that advanced that right heart catheterization may not be necessary at all, but this is hopefully in the near future, but still in the future.
Thank you so much, Gabor. It's very, very important because we have many patients and many patient organizations in the room. I would like to emphasize that we as doctors have developed instruments which are risk stratification instruments, and in North America you have a PHA or PH registry, which has demonstrated quite nicely that adding a patient-reported outcome on top of the traditional measures adds some value. So it means that really together we can build refined instruments which are less invasive, walk test, blood test, functional class, how you feel, but also the true patient-reported outcomes. And I think it was a very, very key information from PHA US, and I wanted to emphasize that. So time is running, and I would like first to mention that the World PH Day is coming very soon. Thank you very much for all the energy you give to this event, and we will have more time to discuss it in the next few days until the 5th of May, which is a big day. I would like to thank warmly PHA Europe, Gergely, Eva, all the people in the room, PHA Association, of course, the European Reference Networks, including ER and Lung, the ERS, ELF, sitting in the room and supporting us for the communication with patient association at the ERS level, Eurodis. So now the closing remarks are for our MEP host, and once again, thank you one billion time for inviting us, and we hope to partner with you very closely in the next future. And the word is
Thank you so much, Mark, and thank you, dear colleagues, if I can tell you, because in this room we are working on the same dreams. So thank you so much, and I hope it will be some kind of historical point, not only because we could meet in person, but we could give us something to do together. So I think it was very important. And my final sentence, thank you so much to Roberta and to Zoltan to organize it. So thank you, Roberta. And please use our networks here in the Parliament, and I'm ready to organize any kinds of events together with you. It is my time, but Zoltan will work on it, so it's very, very easy for me to give this possibility. So thank you so much again, and let's do it together. Thanks.
Thank you once again, and thank you, Roberta. Thank you, Paulina. Thank you, Brian Pipa, the people I work with on a daily basis. And thank you for mentioning them. Thank you also for your very warm welcome at the European Parliament. And thanks also to the multiple stakeholders, including industry, pharma. You were very welcome today. We have emphasized all the discoveries you've made in recent years, and we will do our best to use it for the patient's sake. So thank you very much, MEP Span, and it's really a pleasure to be with you. Thank you.